So why did we study oxaloacetate? So this is a molecule in the Krebs cycle, and what drove the decision to move forward is a paper written by some of the people here that showed there was a deficiency or a decreased level of oxaloacetate in ME/CFS patients. And it's a fairly critical step in the Krebs cycle. These are some of the things that oxaloacetate can do inside the mitochondria. Oxaloacetate, by virtue of this process, can increase or does increase NAD+ levels. It actually can increase mitochondrial mass, biomass, and it can decrease inflammation by keeping the NF-kappa B out of the nucleus. So another way of looking at some of its efficacy or biochemistry, it's this issue with NAD and NAD+, and changing the directions of these two metabolic pathways. And as most of you know, and the patients certainly tell us all the time, a big deal is the lactate and the lactate level. I remember a study that we did with Linda Tannenbaum about 10 years ago called the Severely Ill Patient Study. And when we looked at the data, the thing that popped out over and over was elevated lactic acid, lactate. This process can lower that level, and that may be key to a lot of the fatigue and muscle problems that these patients experience, is it can reduce lactate by affecting NAD levels. In terms of the chronic inflammation, all of our patients, as I'm sure you know, every day they're inflamed. Even if their CRPs, C-reactive protein and sed rates are normal, they are inflamed. That is another role that oxaloacetate may be playing. Mitochondrial dysfunction, I suspect, is a key problem in the post-exertional malaise experience for patients, and this may be another way to deal with it because it can increase the biomass. Also mentioned during the talk is this role of AMPK pathway, which is a key pathway in energy, and oxaloacetate is able to change that pathway and activate it in a very favorable fashion. So that was the idea behind trying it. We did an initial proof of concept trial, totally bad science. Not controlled, no placebo. These were pretty much my patients. I was, to be honest, very skeptical. I did not think this would work as well, but it really worked. There was a significant decrease in fatigue and improvement in the way patients felt, and the numbers were quite impressive. These are long-standing ME/CFS patients, so they're my patients. I know them well. Most of them had at least 10 years of illness. You know, these are numbers that you don't usually see in these kinds of trials, but it was not placebo-controlled. We also did a long COVID as a separate trial. Not my patients, they were recruited from Facebook, so the follow-up was not nearly as good, but we did see some very significant benefit as well. As a result, a new trial was planned. It's an 80-patient trial. It is a true RCT, placebo-controlled, out of a single center, Bateman Horne. It's 90 days, and what I'm going to talk about now is based on the enrollment and preliminary data analysis of 40 patients. So very quickly, I think it's summarized here. The primary endpoint was, would there be any changes in the Chalder fatigue score? These are secondary endpoints. You know, I said that the primary outcome was the Chalder fatigue, but I put this here because I think it's just so dramatic, okay? So this is using a device called Uptime, and I'll show you a picture in a second. So that's the device, and it's worn on the ankle. And basically, it's a way to collect data on how much time a patient spends this way versus either standing or sitting but with their legs down. We see here, that value is pretty dramatic, okay? This is the difference between time 0 and 4 weeks later after being on oxaloacetate for 4 weeks in the treatment group versus the placebo group. All right, so this is looking at the results with the fatigue score with Chalder. And again, we see some pretty dramatic results. I want to spend a second talking about the placebo group. In the first paper, proof of concept, we made a point that one of the reasons we didn't have a placebo, or maybe it would be still useful without a placebo, is work in the past where the placebo effect in ME/CFS patients was relatively small, but way smaller than most other studies have seen in other kinds of patients. So when I first saw this data, I said, wait a minute, what happened to our lack of placebo effect in these placebo patients? And we think it's because they knew they were in this trial. They had heard about the trial. They had read the paper. They had seen the IACFS recordings or at the meeting last year, and so they had high expectations. But nevertheless, if you compare the treated patients, there's a very significant decrease in their fatigue levels. Okay, so just a quick summary. We used the 2,000 milligram a day dose, 1,000 milligrams dosed twice a day. That was sort of the sweet spot in the first study, and that's how that dose was selected. It's given usually in the morning with a meal and at lunchtime with a meal, and that's because if you take it in the evening, it may keep you awake at night. It's given with a meal because it can cause some reflux or gastritis type symptoms, and it doesn't happen if you use the meal. This is referencing the data I showed before, 30% decrease in fatigue. I have to say my favorite piece of data here is the uptime. Yes, it's great to have people say they're less fatigued, but that's manifested functionally by seeing them get out of bed and do something, or at least stand more. Okay, so moving forward, there's a bunch of trials planned or in process. We are starting a long COVID trial with similar design, although I think the dose we'll use is a little bit lower based on the previous trial I mentioned. It will also be done at Bateman Horne, and then there are some other trials going on, fatigue in breast cancer, and then how mitigate fatigue in patients who've received radiation. And then this is one I'm particularly want to see if we can somehow pull off. I've received and read much anecdotal emails from patients, severely ill patients who say, can I please have more? This is the first time I can do anything. So that's the basis to try to do this and to use the higher dose. And as somebody asked earlier today, how are we going to measure an improvement in a 100% bed-bound patient? And that's kind of a challenge, but I hope we can pull this trial off. So these are some other ongoing trials. This one is in process now. The ALS trial is in progress, and I've seen anecdotal emails from ALS patients saying, this is working, my disease is either slowed, I can do things I couldn't do before. It works. It has enough efficacy at the 2,000 milligram dose. It is safe. There's been no adverse effects to speak of. Chalder has been very helpful and clearly shown a decrease in fatigue. And again, physical activity has increased. Hopefully when we fully enroll and analyze the 80 patients, we'll have even more data to present.